hospital-acquired as well as ventilator-associated pneumonia. So, I'm sorry. So what did we learn? We learned how to, identify the clinical syndrome, understand and correlate with imaging, oxygen requirement, and microbiology, stratify the risk, whether it was whether the patient has low MDR or high MDR or Pseudomonas risk, right empirical treatment, how is it chosen? How do you correlate it with the severity and the antibiogram in your setup? Then reassessment and the prevention bundles. So every prescription should have a diagnostic plan, dose plan, and a reassessment plan. Now, what I want to emphasize here is that when you have a patient in whom you're suspecting, do not delay treatment, especially when the patient has a severe HAP or VAP infection, because it can quickly convert into a septic shock, ARDS, multi-organ failure. Obtain cultures as soon as possible, but do not delay treatment in order to obtain samples, especially in patients who are unstable. And initial coverage should have therapy which should be active against the likely pathogen that you're suspecting. Avoid over-treatment because endotracheal aspirates can have colonizers. So again, clinical correlation and patient's presentation matter. Broaden for real MDR risk only, and especially in patients who are in shock or have history of prior isolates. And of course, de-escalate appropriately. So a word about the clinical as well as the surveillance definitions. Now, clinical definitions are used for the purpose of treating the patient. Surveillance definitions primarily use ventilator-associated events, and they are majorly used for benchmarking and reporting purposes. So briefly, definitions. Hospital-acquired pneumonia is that occurs more than 48 hours after hospital admission and not incubating at the time of admission. Ventilator-associated pneumonia is the pneumonia that develops more than 48 hours after ET intubation and initiation of mechanical ventilation. Ventilator-associated tracheobronchitis is patient with infection of the tracheobronchial tree, presence with fever, purulent secretions, even a positive culture without a new pulmonary infiltrate on the radiology. And ventilator-associated events, like I told you, are used for surveillance purposes, have been given by CDC, and they are not synonymous with the clinical definition of ventilator-associated pneumonia. So why is it difficult to diagnose? Because there is no perfect gold standard. Patients may have fever, leukocytosis, infiltrates, and even secretions because these are common things in the ICU. Radiology, X-ray has a specific and limited sensitivity and specificity. Patient may even have atelectasis, ARDS, or even edema. So you should be able to differentiate. Cultures can be misleading because ET aspirates often grow colonizers, and oxygen requirement increasing PF ratios may worsen even in patients with fluid overload, collapse, embolism, or ARDS. So it should be a diagnosis is a probability judgment, and you treat the patient as a whole, not a single culture and not just a chest X-ray. So when do you clinically suspect? You walk into the ICU in the morning and, on rounds, your staff tells you that they are noticing that there is an increase in the secretions. You look at the patient and you see that the patients ventilate. There's a lot of asynchrony. The PF ratio is rising on the ventilator. The patient has developed a fever today. The counts are showing an increasing trend. The biomarkers are showing an increasing trend. And then, you look at the X-ray and you see that there is a new infiltrate or a new consolidation that the patient has developed. So these are the clinical bedside suspicion parameters. And when you send in the microbiology, if you're sending the ET aspirates, you should be able to correlate it and rule out colonizers specifically. BAL, of course, becomes more specific, but then it has to be clinically correlated in all patients. A brief about pathogenesis. So we know that there is a risk of a lot of colonization. It starts right from the level of oropharynx, gastric contents, poor hand hygiene practices, and of course the immediate environment of the patient. Risk of microaspiration because of increased secretions, leak around the cough, and the ET tube having a formation of biofilm, which acts as a microbial reservoir. Then these patients are usually in supine position, they're nursed in supine position, they're often given sedation, they may have a weak cough reflex. So all of this would lead to inflammation, increased purulence, impaired gas exchange, and respiratory failure. Similarly, for hospital-acquired pneumonia, risk factors can start right from the host being vulnerable to patients with risk of aspiration, the hospital flora per se, and failure of clearance of secretions by the individual. So, HAP prevention includes oral care, mobilization, dysphagia precautions, and avoiding unnecessarily antibiotics and devices, especially when they are not needed. So, what are the risk factors for both ventilator as well as hospital acquired pneumonias? Ventilator related patient has been on prolonged duration of mechanical ventilation, on tracheostomy, you've re-intubated the patient. Overall, the host is an elderly individual with a long-standing COPD, structural lung disease like bronchiectasis, malnourished, diabetic, CKD patient, or those who are immunocompromised hosts. Then patient has been in for a prolonged stay in in the hospital, or has had prior ICU admission, recent antibiotics, invasive devices, nursed in supine position, enteral feeding intolerance, sedation and dysphagia can lead to risk of aspiration. And of course, at the level of implementation as well, poor hand hygiene practices, cuff pressures are not checked daily, and the audits are not done properly. So these are also important aspects, especially in cases of prevention, and they pose as risk factors. So when we look at risk factors for MDR infections, which are again very prevalent and common in our Indian ICUs, what is an MDR infection? When the microorganism is not susceptible to at least one agent in three antimicrobial categories. What is an XDR? When the microorganism is not susceptible to most of the antibiotics, but maybe one or two antibiotics in one or two antibiotic classes. And pan drug resistant becomes when the microorganism is resistant to all the drugs in all the classes. So this is just to, recapitulate. And we see a lot of XDR, Acinetobacter, Pseudomonas, MDR, ESBL, CRE, which pose a lot of threat, as well as VRE and MRSA in certain ICUs. So, what are the risk factors which lead to MDR infections? Antimicrobial therapy for more than 24 hours and last 30 days, hospitalization beyond 5 days before pneumonia onset, known colonization with gram-negative MDR Pseudomonas or MRSA, patient in septic shock and ARDS, patient on hemodialysis, or there is a higher MDR carriage risk in the healthcare centers, as well as patients with structural lung disease, because they are at a higher risk of developing Pseudomonas infections or history of prior Pseudomonas isolation. So you have to remember these risk factors because you need to accordingly choose your empirical therapy in your patients when they develop the infection. So in Indian ICUs, the MDR risk, you need to remember what you need to check is unit specific antibiograms. Stick to your unit specific antibiogram, know your antibiograms. Avoid copying Western low MDR empiric regimens blindly. Starting colistin for every ventilated fever. Treating colonization without syndrome relevance. Then delaying active therapy in patients who are in shock. And continuing combinations even after you've received your antibiotic susceptible therapy and not de-escalating appropriately if it is required. So what would your diagnostic workflow look like? You have a patient with the specific clinical syndrome. You look at the radiology, the oxygenation change, the imaging, and then you decide that you're suspecting a HAP or VAP. You stabilize the patient, you take care of the airway breathing circulation, send appropriate samples. Remember, when the patient is very sick, do not delay therapy in order to send samples. Samples should be sent in all patients, but do not delay therapy just to send the samples. Imaging, chest X-ray remains standard, and ultrasound is a useful bedside tool. CT if there is unclear diagnosis or complications. Start empirical therapy, know whether there's an MDR risk or not, and assess severity, and then review at 24 to 48 hours. So, a word about imaging. Like I said, chest X-ray is the first bedside test that we generally do for all our patients, and it gives you an idea about what you're dealing with. It'll identify the new infiltrate, the consolidation. If there's a mimic, it would also tell you about that. Lung ultrasound is very useful. It is readily available at bedside in most of the ICUs. You can quickly look uh, at the bedside for consolidation, dynamic air bronchograms, pleural effusion, and you can subsequently do guided drainage as well. But it is operator dependent, it is sensitive, and you have to correlate it. CT you only do when the diagnosis is uncertain, you're suspecting complications, or your mimics require specific exclusion. So in microbiology, we send blood cultures in all patients with severe infections, endotracheal aspirates in most of the ventilated patients, BAL and mini BAL, and uh, pleural fluid becomes specific for source control in patients who present with it. So, what is the advantage of bronchoscopy versus non-bronchoscopic sampling? Remember, a non-bronchoscopic endotracheal aspirate or a mini BAL is quick. It's easy. You send the sample quickly. So obviously you will achieve the results early. But you need to remember that there is a risk of colonization. So you should be able to differentiate and correlate. Bronchoscopy is useful in patients who are immunocompromised and when there's a diagnostic uncertainty. It helps you to evaluate obstruction, bleeding, and other opportunistic infections. But you should avoid it if the patient is hypoxemic or is hemodynamically unstable. A word about rapid diagnostics and multiplex PCR. We all know that they help us to get rapid diagnosis and start early target therapy early. But you need to remember that you should be able to differentiate the possibility of colonization in these as well. Always send culture and antibiotic susceptibility testing in all the patients in whom you are sending your rapid diagnostics or multiplex PCR. Then how do you differentiate colonization versus true infection? If you receive a culture sensitivity report, your patient is improving and there are multiple organisms, don't start changing antibiotics for each organism based on the culture sensitivity because they could all be colonizers. If your patient is getting better, you can continue or even de-escalate your regimen. Candida and Enterococcus in your endotracheal aspirates rarely cause pneumonia. They're mostly colonizers. Pseudomonas and Acinetobacter again would require syndrome plus imaging plus oxygen change. So it would require clinical correlation to rule out that it is whether true infection or a colonizer. And similarly, sterile site, like if you've sent a pleural fluid or a lung tissue, so it has much stronger evidence. So you should treat and you should simultaneously achieve source control in these patients. We've talked enough about mimics to remember whenever you get a patient like this, remember mimics like atelectasis, mucus plug, pulmonary edema, ARDS, pulmonary embolism, diffuse alveolar hemorrhage, as well as drug pneumonitis. You must remember this before just tagging your patient as hospital acquired or ventilator associated pneumonia because the patient may actually have any of these and not a true infection. So what does your empirical therapy look like? How do you plan it? So empirical therapy is obviously you've confirmed the clinical syndrome. You assess the MDR risk based on the risk factors that we just talked about. Then you choose the right drug, gram-negative coverage, MRSA if the risk factors are present, and anaerobic only when it is needed. Then you load. We've talked about this as well. Always give full loading dose irrespective of the patient's renal function in critically ill patients, and you adjust based on the renal phenotype and in obese patients, and we review at 24 to 48 hours. So how would your empiric selection look like for an antibiotic in patients who do not have risk for MDR bugs or Pseudomonas? So in early non-severe HAP, generally a single active beta-lactam as per your local antibiogram is usually enough. Patients who develop HAP in ward with aspiration risk. So you do not add anaerobic cover unless you are suspecting the patient to have abscess, empyema, and necrosis. Remember, in case of abscess and empyema, you need to achieve source control simultaneously, drain that empyema. Stable patient with low MRSA risk, avoid routine vancomycin linezolid cover. Stable patient with low Pseudomonas risk, avoid anti-Pseudomonal escalation if your local data supports. And how would your empiric selection look like in patients with MDR and Pseudomonas risk? So prior ESBL or high ESBL unit, carbapenem may be justified in severe disease. Structural lung disease, like I said, there is an increased risk of Pseudomonas or history of prior Pseudomonas isolation, anti-Pseudomonal beta-lactam based on prior AST testing. Then prior CRE or high CRE risk, so mechanism-aware therapy, use carbapenemase tests and AST. Prior CRAB or outbreak, so you do not rely on empirical regimens. You distinguish in case of Acinetobacter, colonization versus true ventilator-associated pneumonia. A patient who's in shock with MDR risk, you may start initial combination coverage as a short bridge until your antibiotic susceptibility testing is available, and then subsequently decide your final therapy and plan treatment. So I was just talking about combination therapy. You should use combination therapy briefly in patients who are in septic shock, have additional MDR, Pseudomonas risk factors present, and you're awaiting your AST results. Avoid routine combination when the patient is stable without MDR risk. One active beta-lactam is confirmed. Toxicity risks outweigh the benefits. And combination, you just keep continuing even after you've received your AST. You need to de-escalate. You need to narrow down if your patient does not require that combination that you started as an empirical therapy. And cultures are, now showing you colonization, or you've ruled out that this is a mimic. Even then, you should de-escalate. MRSA coverage is required for patients with prior MRSA colonization infections, severe necrotizing pneumonia, or post-influenza pattern, line or device source, or when there's a bacteremia concern, or there is a high MRSA prevalence in your unit and patient is presenting with severe HAP and VAP. Carbapenemase resistance, Enterobacter C. So, these days, in most of the tertiary care setups, there is available tests for detecting the gene resistance. So, if it is available, you should use it, send it, and if you get OXA48 positive, the drug of choice is ceftazidime avibactam. If NDM or MBL CRE is positive, then Astronam or avibactam strategy, or cefderichol, although not available in India. KPC CRE, again, it is fortunately less common in the Indian ICUs. So again, ceftazidime avibactam remains the drug of choice. Meropenem, viborbactam, imipenem, relebactam are again good choices, but they are not available in our country. Then difficult to treat Pseudomonas. If the Pseudomonas is susceptible to a traditional beta-lactam, then use an active anti-Pseudomonal beta-lactam and optimize the dose. If you're dealing with a difficult to treat Pseudomonas, then ceftazidime avibactam or fosfomycin are good choices. Other combinations like ceftriaxone, tazobactam, imipenem, relebactam, and cefderichol, if the isolate is susceptible, not available in our country. Then a word about crab infections. Remember that when you have a resistant Acinetobacter, it is generally considered that an Acinetobacter species is inherently sensitive to sulbactam. So the regimen becomes sulbactam containing, which is the central. In our country, we use high-dose ampicillbactam based combinations. We would give minocycline, TG cycline to our patients. Polymyxins and colistins are also very widely used, but these days, because of the problem of toxicity, it is preferred that you use polymyxin sparing regimens and avoid using them as a reflex. And sulbactam, durlobactam is the combination of choice wherever available. A word about PKPD. We know that for beta-lactams, we give full loading dose in severe infections, and you do not modify loading dose based on the patient's renal function. Extended or prolonged infusions in critically ill patients, you adjust the maintenance based on the renal phenotype and those who are obese or those with hypoalbuminemia. You monitor for drugs toxicity and as well as response, and you review the patient based on MIC response toxicity and if you can de-escalate. Inhaled antibiotics not used routinely. used only when MDR gram-negative pathogen with limited systemic options and when it's only susceptible to colistin or aminoglycoside or very difficult to treat infection. So what does your early assessment look like? Your early assessment would be based on clinical parameters. Has your patient's fever started to subside? How's the work of breathing, the oxygen demand, the shock, and the mentation? What are the ventilator requirements? How are the secretions responding? Then what are your cultures and your AST showing you? Do you need to modify treatment at this point? What is your imaging trend showing you? Is that consolidation getting any better? Is it changing or is it persisting? Then accordingly, you decide based on the patient's improvement or deterioration. So what would your reassessment outcome look like? Your patient is improving, so you can start de-escalating or narrowing down. And you can accordingly, modify your treatment based on the patient's response. And by this time, you would have your culture and antibiotic susceptibility testing also available. If the patient is stable but still unclear, so at this point, you may have to check your sample quality. What kind of sample did you send? What is your imaging trend showing you? The biomarker trend. Are you dealing with something else? Is it not really an infection? Is your drug dosing appropriate or not? So just because your patient is stable but things are not improving, don't automatically start escalating antibiotics. And the patient is worsening, then you broaden only if your coverage was inadequate. If you need to achieve some source control which you did not do initially, are you now dealing with some complications or resistant pathogens? So it would all depend on the patient's underlying presentation. Duration of treatment. For uncomplicated HAP VAP with good clinical response, usually 7 to 10 days is the adequate duration. For patients with Pseudomonas, Acinetobacter, MDR gram-negative HAP VAP, generally 7 to 14 days, but do not prolong solely because the pathogen was a drug-resistant pathogen. Patient with persistent fever, leukocytosis, worsening oxygenation, you reassess the diagnosis first. Look whether you've achieved source control or not. And are you dealing with resistance at this point? Individualize treatment and not generalize and just escalate because the patient is worsening. Staph aureus bacteremia, more than 14, at least 14 days minimum for uncomplicated infections and 4 to 6 weeks if complicated. Infective endocarditis, usually 6 weeks or more, but this again becomes organism and valve specific. Empyema, remember source control. You need to drain that empyema and 2 to 6 weeks, again guided by source control and response. For patients with metastatic infection, necrotizing pneumonia, lung abscess, typically 3 to 8 weeks. And of course, it is site specific and radiology guided. Biomarkers useful as not as the decision makers for choosing the empirical therapy or deciding on your antibiotic therapy, but for de-escalation and maybe for assessing response. So do not use PCT or CRP alone based on the trend, the value, and don't use one single value. Use trend for these biomarkers, both for procalcitonin as well as for CRP. And it would depend upon the clinical response, the microbiology, imaging, source control. So it has to be an integrated process, not just getting one value of procalcitonin and escalating or de-escalating your therapy. Don't do that. So what would the prevention look like? The patient has been in the hospital. If you implement good practices, you might prevent that infection from developing. So you have to have simple evidence-based practices. You need to train and educate your staff. You need to have proper surveillance systems in place, audit what you've implemented, and then have a proper feedback system to understand whether the implementation has actually taken place and is it actually helping in prevention of these infections from occurring. So we know that every surface in the ICU, whether the bed rail, the monitor, or the doorknob, can harbor organisms that no antibiotic can kill. So you must disinfect surfaces every 8 to 12 hours in an active ICU and not just once daily. So this has to be implemented. This has to be taught to your staff. And environmental decontamination, priority services, surfaces that I just talked about, terminal cleaning, after discharge transfer, of the isolation rooms, and enhanced technology like UVC and hydrogen peroxide vapor. Yes, they may support terminal disinfection, but it does not replace manual cleaning. So you need to have decontamination practices in place, clean, disinfect, audit, and have a proper feedback mechanism in place. Do not blame resistance only on antibiotics because contaminated environments can sustain transmission. So what are the everyday items that you look at for prevention? Hand hygiene, very important, because hand hygiene in itself is one of the most powerful intervention, and it reduces MDR transmission by up to 50%. So before coming in contact with the patient, before aseptic task, before after handling patient's body fluid, after patient contact, after touching patient surroundings. It is one of the most single and most powerful intervention if implemented properly and practiced every time. You must reassess your patients daily for extubation. So spontaneous breathing trial, if there's no contraindication, should be given to the patient daily. And you must assess the patient's mentation, whether he'll be able to protect his airway or not. Cuff pressures. Now, cuff pressures generally recommended on an average 22 to 25 is a good cuff pressure, because below 20, there is an increased risk of aspiration, developing VAP. Above 30, it would result in mucosal injury, ischemia. So you want to maintain your cuff pressure. And if you are suspecting your patient to be intubated for beyond 48 to 72 hours, use tube with subglottic secretion drainage port, because we use usually those for endotracheal as well as for tracheostomy tubes in our ICUs. Then then you remember that you must minimize the duration of mechanical ventilation. It is important. Avoid reintubation. Don't be in a hurry to extubate your patient. Check if the patient requires HFNC or NIV post extubation. Then oral care. It should be again emphasized upon. Do not rely only on chlorhexidine as a routine universal VAP prevention solution, because oral hygiene can be mouth because can become a reservoir for aspiration, dental plaques, and poor oral hygiene increase the pathogen burden. So you need to implement this. You need to teach your staff. You need to emphasize upon it daily and check whether they are doing it properly or not. Then positioning and mobilization. Nurse your patient in 30 to 45 degrees head and elevation. Mobilize your patients daily if there is no contraindication. Suctioning should be brief, and you should avoid routine saline lavage because it increases the risk of contamination, as well as in hypoxemic patients, it just worsens the oxygenation. Humidification should always be maintained. A lot of times the nursing staff would remove the HME filter for nebulizing and then forget. So you have to emphasize, teach your staff to put it back once they've nebulized. And physiotherapy should be targeted. It should not be a routine ritual. Selective digestive decontamination is good in places where the local AMR burden is low and surveillance is strong. In Indian ICUs and our setups with the high AMR burden, we don't practice selective digestive decontamination anymore. Not advisable as a routine VAP prevention, routine oral chlorhexidine, circuit changes unless they are soiled or they are malfunctioning, kinetic beds prone solely to prevent VAP, routine stress ulcer prophylaxis, routine gastric residual monitoring, and early parenteral nutrition. What you should not do. Do not diagnose SWAP from culture alone. Do not overuse carbapenem and colistin because we have high antimicrobial resistance. Do not forget source control. Just cultures and antibiotics is not going to treat your patient if you don't achieve that source control. And do not continue beyond 48 to 72 hours when you can see that the patient is getting better. Your AST is showing you appropriate results, which is telling you that you can de-escalate. So to summarize, diagnosis is a probability of HAP and VAP. So do not treat culture, chest X-ray, or fever alone. MDR risk must be explicit. You need to remember your MDR risk factors before initiating patient or empirical treatment. Dose matters. Always give full loading dose. for beta-lactams and prolonged or extended infusions in critically ill and modify based on the renal phenotype and obese patients. Reassess early at 48 to 72 hours. And prevention is daily work. So head and elevation, oral care, cough, spontaneous breathing trial, mobility, circuit discipline, surveillance, and having a feedback system in place always matter. Thank you.